The following podcast is part of a certified educational activity titled A New Treatment Era for Light Chain Amyloidosis, Interprofessional Lessons from a Center of Excellence. Access the entire activity and complete the post-test at peerview.com/KKH860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Suzanne Lensch from Columbia University Medical Center in New York. I welcome you to this panel discussion on exploring a team-based approach to managing AL amyloidosis. I'm pleased to welcome my cardiology colleague, Dr. Matthew Maurer, as well as our nurse practitioner colleague, Margaret Kumo. During this program, we will use a case-based approach to discuss the challenges and complexities of recognizing, diagnosing, and managing amyloidosis in the modern era. Let's begin. I think in the first quarter of our discussion, it will be important to discuss guidance on recognizing and diagnosing light chain amyloidosis. And let me start asking Dr. Maurer. Matt, maybe you go ahead and you present a case of an AL amyloidosis patient you see in your practice. So what is a kind of an interesting amyloidosis patient?
Yeah, thanks, Suzanne, and I appreciate the invitation to be with you and Margie today. So let's start with an initial case. This is unfortunately the norm and something that I think we're trying to change. But here's a patient, Michael, who's 62 years of age, and he has progressive shortness of breath for 2 years prior to his initial referral to an outside doctor. At that point in time, he had an electrocardiogram, which was read as showing a silent MI. We'll comment on this further, but a pseudo-infarct pattern is not atypical in patients with cardiac amyloidosis. They have Q waves, but no segmental wall motion abnormality to actually suggest a previous MI. And he originally presented with atrial fibrillation that was paroxysmal, would start and stop, but became persistent. And he underwent, at the time of his presentation, a coronary angiogram, which showed minimal coronary artery disease. And unfortunately, I think it wasn't appreciated that his left ventricular end diastolic pressure was elevated at 19 millimeters of mercury, indicative of a heart failure syndrome. He was subsequently treated with diuretics and as well as standard heart failure therapy, including ACE inhibitors and beta blockers, and actually felt pretty miserable with the latter therapies. Kept complaining, he said, to his doctors, but they said, no, this will eventually help you. He had a worsening cardiac status. His ejection fraction was still preserved, and he had an increase in wall thickness. And eventually he progressed to having a large right pleural effusion that was tapped. The cytology was negative, and this was thought secondary to him having heart failure. And now 2 years after his initial presentation, he now has a reduced ejection fraction with an increase in wall thickness. And because he's in persistent AFib, with a very fast ventricular response, he undergoes an AV node ablation and has a BiV pacemaker placed. And he is, at that point in time, frustrated and upset and is referred to our center to see us for evaluation. And I think this case highlights a very important point, and that is if you don't entertain the diagnosis of amyloid in your differential, you're never going to make it. As data has been highlighted from Isabel Lusada, who's the president of the Amyloid Research Consortium, she polled patients who were eventually diagnosed with amyloid, and 75% of them said they had to see at least 3, if not more, physicians until a diagnosis was made. And in more than 60%, it took greater than 6 months to make a diagnosis. Many of them, of course, received an incorrect diagnosis first, I think air travel to establish the diagnosis is not unreasonable. In fact, there are support groups that do provide support for patients to travel to centers of excellence. But notably in the cardiovascular community, it's cardiologists who were the subspecialists most likely to make a misdiagnosis. They most commonly said that patients had a hypertrophic cardiomyopathy when in reality they had amyloid. Having seen nearly 1,000 patients with a cardiac amyloid at our center, I can tell you there are several reasons why this diagnosis is missed. First, it really is an underappreciated cause of the syndrome of heart failure in the setting of a preserved ejection fraction. And as we'll highlight, there are lots of kind of clinical clues. There are some misconceptions about the diagnosis. Cardiovascular providers are taught that an EKG is a very good screening test. And as I'll highlight in a minute, we're taught to look for low voltage, but low voltage is highly specific for amyloid, but is insensitive, and it's actually a late phase phenomenon. It's not something that's going to give you a really early clue. Additionally, a fat pad biopsy is actually a reasonable test for, if you will, AL or light chain amyloid, has even a lower sensitivity for TTR. But even in the best circumstances, its sensitivity is not much above 60 or 70%. So I would just ask you, if you have a life-threatening condition, you do a fat pad biopsy, you suspected amyloid and it's negative, are you going to stop the workup there? And I hope the answer is no. Given that sensitivity, there's a great chance you're missing amyloid with a negative fat pad. As I mentioned, and we'll highlight in a few minutes, Margie Cuomo, our expert nurse practitioner, will go over some of the clinical clues for a very prepared clinician if you're thinking about this diagnosis. There's been an explosion in the arena of cardiac amyloid, giving the plethora of new therapies and new diagnostic approaches. And particularly, one should be aware that transthyretin cardiac amyloid, that is due to the precursor protein prealbumin or transthyretin, can be actually now diagnosed pretty definitively by scanning techniques. But AL amyloid still requires a biopsy. You can't make a diagnosis without it. And probably most important change is that most clinicians have a pretty nihilistic view about amyloidosis, and they really feel like, this is a disease that's nearly terminal. In fact, maybe I'll just ask Suzanne. I mean, my sense is we've been diagnosing people earlier and earlier, and they've been living quite a bit longer. What's your experience in this particular circumstance with regards to early diagnosis?
Yeah, absolutely. I always say when patients have an early diagnosis of AL amyloidosis, the life expectancy is much better than multiple myeloma. So patients really with an early stage 1 and treatment that brings the patient into a complete remission, those patients very often have a low plasma cell burden, go into a long-term remission, and outlive, multiple myeloma patients by many, many years. In fact, I have patients who had 2 heart transplants and kind of 1 renal transplant. I mean, those are really kind of very rare patients. But what I wanted to say is that the organs are so damaged that they failed, but the plasma cell clone didn't come back and allow really a long-term survival. So I think really key is the early diagnosis, and and I will talk later about that, really to bring patients into a complete remission.
Yeah. And I would imagine, Margie, you'd probably agree that when we diagnose people earlier and they don't have a severe phenotype of heart failure, management is much easier, right, than the more advanced patients who's kind of low labile and difficult, correct?
Yes, absolutely.
Yeah. So for this particular patient, he underwent some cardiac testing, which is shown on the following slide. And I think you can appreciate here, he had unfortunately had a pretty advanced phenotype. And you can see on the EKG, there's a diffusely low voltage with especially in the limb leads, but also in the precordial leads. And there's also a poor precordial R-wave progression, or a pseudo-infarct pattern. And you can see to the right his echocardiogram. Probably this is an echo that's not only measuring the wall thickness, and you can see here the increase in wall thickness kind of in the septum. That's probably in this point greater than 2 centimeters. But also we're leveraging here a technique of what we call speckle strain, in which the ultrasound technique is able to label the myocardium, put these little dots, if you will, along the myocardial borders, and then measure the degree of shortening of the distance between the 2 points. And the more the muscle shortens, that's the greater the strain or more negative it is. And that appears in red as more negative or good strain, usually in the realm, as you can see in the right, of -20. And at the base of the heart, near the mitral valve, you can see the color coding suggests that it's kind of a pale or blue color. There's less shortening. There's not as much movement. This pattern of so-called apical sparing is very typical in patients with cardiac amyloidosis and highly suggestive. And this patient has, at the bottom, you can see a global strain of -12%, which is abnormal. So despite having a preserved ejection fraction and a clinical syndrome, there's a lot of clues here. Most importantly, the discordance between the wall thickness on the echo and the EKG findings. As I mentioned in a series that we published several years ago in the American Journal of Cardiology, we investigated the utility of the EKG. And I think, as you can see from these bar charts here, in 210 patients with biopsy-proven amyloid, both AL and TTR, low voltage on the EKG or in the precordial leads was seen in less than a third of patients. So not very sensitive, even though they all had biopsy-proven amyloid. Was highly specific and prognostic, but that's not when you want to identify a patient when they're in advanced stage. And additionally, you can see here that the poor precordial R-wave progression, the pseudo-infarct pattern, or actually the best is integrating the voltage on the EKG with the wall thickness on the echo, so-called the voltage to mass ratio, and that was much more sensitive. So for this particular subject, who you now have a intense clinical suspicion of amyloid, I think what you want to do is certainly assess for light chain amyloid. While it may not be the most common form of cardiac amyloid, it's certainly the most deadly. And the way we do that is serologically to look for serum-free light chains, so-called the kappa lambda-free light chain ratio. And also to look for the serum protein immunofixation or electrophoresis with immunofixation and urine protein electrophoresis. It's important to make sure you're asking for immunofixation to tell the laboratory you're looking for small light chains. And if any of those tests are positive, the substrate is present for AL amyloid, and such patients, I believe, should be referred to hematology. You should engage expert colleagues like Dr. Lynch. At the same time, when we're seeing a new patient, we often measure cardiac biomarkers, the so-called NT-proBNP and a troponin that are helpful, as we'll hear, in risk stratification. And then obviously we've already gotten an echo, but I would point out that while the ejection fraction and wall thickness are the most common things reported on an echo, they're not very prognostic. And as I mentioned, either global strain or the stroke volume are much more prognostic in patients with cardiac amyloidosis. So I'll turn it back over to Dr. Lynch.
Let me come back to GLS, the global longitudinal strain. We hear a lot about that. So can a hematologist just order a GLS? I mean, I'm seeing that from the perspective of a hematologist. The echo gives me, to be very honest, as a non-cardiologist, some limited information. That's why probably hematology likes MRI. So I look for diastolic dysfunction. Very often it is not really reported, so I'm missing this one. I should not really take into account the interventricular thickness. So what is left for me if GLS is not reported? Can I request it? Any comments on this? Because I think it's a very important marker.
Yeah, I mean, I think in the broad world of, if you will, cardio-oncology, most echocardiographic laboratories are performing global longitudinal strain. It's clearly a important measure that tells you in the setting, certainly of a preserved ejection fraction, that there's still a myocardial shortening problem. The other, quick, fancied approach that we invented several years ago was something called the myocardial contraction fraction, which you could also calculate on a regular echo, and that's the ratio of the stroke volume to the myocardial volume. In general, a normal MCF is somewhere above 40. Myocardial contraction fraction, or MCF, is a kind of a global poor man's measure of strain. But to your point, Suzanne, I think measuring strain should be a standard. It's one of the more sensitive markers of disease, and it's something that you can track over time. It also helps engage the patient quite a bit.
Okay, perfect. Thank you. Margie, you see many, many cardiology patients, and I think one of your jobs is also to filter a little bit who might have amyloidosis. And tell me a little bit, what are the red flags of amyloidosis? And if you think the patient might have amyloidosis, is there anything we can really clinically differentiate that or might help us to say, oh, this is more likely AL or TTR amyloidosis? So tell us kind of, about your experience from a day-to-day business.
Sure. Thank you, Suzanne. I'm happy to be here. Thanks for including me. So the nurse practitioner, really any clinician, can play an important role in picking up some red flags of AL amyloidosis, particularly in a good patient history or physical exam. So you may have seen this image before, which kind of highlights all the many different potential signs and symptoms of amyloidosis, a little bit of an overwhelming picture. In particular, I think a lot of emphasis has been given to the hallmark signs of the periorbital ecchymosis or macroglossia or enlarged tongue. These are kind of those hallmark features that we always hear about. And while these are highly specific for AL amyloid, they're not very sensitive. In fact, only like 10 to 12%, I think, of patients will ever develop these signs. And kind of similar to the low voltage EKG that Dr. Moore was mentioning, you certainly don't want to wait till patients present with these signs because it may never happen. So, of course, Matt and I work in advanced heart failure, so we're always focusing on the heart. And indeed, about 65% of these patients will develop this infiltrative cardiomyopathy. So you may see symptoms of heart failure, which may present as new or worsening dyspnea on exertion or a change in their exercise tolerance. And we're in New York City, so we're always talking in blocks. So they may say, I used to be able to walk 10 blocks, and now I can only walk 2 blocks. This is certainly a concern and a red flag. GI motility issues are also very commonly seen with these patients. About 20% of them will have complaints such as diarrhea, constipation, early satiety. Those should definitely be considered red flags if there's a clinical suspicion there. Peripheral neuropathy is also seen quite a bit, and this is in patients who don't have a history of diabetes or any other reason why they should have a peripheral neuropathy. Autonomic dysfunction is another big one, particularly orthostasis. So they may say that they're getting, dizzy when they're getting out of bed in the morning or with quick position changes. They may feel presyncopal, or in more extreme cases, they may have passed out in the past, or they may have new sexual dysfunction. And another important clue when you're collecting history from a patient, which Matt touched on in our case, but they have this growing intolerance to neurohormonal blockade or antihypertensive medications as well. So sometimes we'll see patients who have had a diagnosis of hypertension since they were in their 30s or 40s, and now all of a sudden, they're thrilled that their blood pressure is under better control and they no longer need their medications. And this is not a normal thing, and it's not usually a good thing. So that's definitely a huge red flag. And some patients have gotten so far as to have the diagnosis of heart failure, but they haven't, nobody's discovered that it's AL amyloid causing the heart failure. So they may have been placed on neurohormonal blockade like ARNI therapy, beta blocker, and they're feeling terrible on these medications. So that's another red flag. And then moving on to the physical exam, some key features which should alert you to the possibility of AL amyloid. And then after diagnosis, it's also important to kind of pay close attention to these parts of your physical exam because they give you clues as to how the patient's doing. Orthostatic vital signs are a basic thing that are helpful and can raise your suspicion if the systolic blood pressure is dropping 20 points when the patient gets up from a seated position. That is not normal. Periorbital purpura and macroglossia, which we discussed, again, highly specific. Cardiac-wise, you want to pay close attention to heart rate and rhythm. Atrial arrhythmias are definitely more common in this patient population, so they may be presenting with new atrial fibrillation. And symptoms of heart failure, particularly right heart failure, signs of fluid overload such as edema. A lot of times, especially in more advanced cardiac amyloidosis, they'll have elevated JVP on exam. And then when listening to the lungs, you may notice diminished or absent lower lung breath sounds, particularly on the right side, which is where patients tend to develop pleural effusions, such as our patient in our case study today. And then with the abdominal exam, you may see abdominal distension, ascites. They may have an enlarged liver. Actually, about 20% of these patients do have liver involvement, so that's not uncommon to see that. And they may, on exam, have hepatojugular reflux. So when you're pressing on the liver, you'll see that JVP distend. And again, I know this is it's easy to list these symptoms in like a laundry list type fashion, but it's a little bit harder to identify in clinical practice. So you can see why it takes so long for some of these patients to get a diagnosis. So as Matt always kind of reminds myself and our colleagues, you really have to keep amyloid in your differential to really kind of put these clues together.
Absolutely. Thank you so much, Margie. I mean, this was excellent. And I think what you just said reflects 2 points. First, it shows how unspecific the symptoms can be in AL amyloidosis or in amyloidosis. Everything can be, I would say, related to aging. And many patients say, I'm getting old and I don't feel really well recently, some digestive issues. I think as a hematologist, for us, the red flag should be always if a patient with an MGUS, especially the lambda MGUS. Remember, 80% of the AL patients have lambda amyloidosis and have a lambda light chain clone as an underlying clone. If those patients have any unspecific symptoms, what Margie just discussed, really do a fat PET biopsy. It's such an easy procedure. Keep an eye, can this be AL amyloidosis? What it also reflects is the importance of a thorough clinical examination. I think if it is in other cancers, maybe less important. In AL amyloidosis, you need to examine the patient. You need to ask for abdominal distension. You need to look, whether there's peripheral edema. This is so important, not only the first time you see the patient, but also during the course of the treatment, especially when the patients come during chemotherapy. So again, listen to your patients and make sure that you do a thorough clinical examination. But let's come back, Matt. Maybe you as a cardiologist can also help us, hematologists, to better explain the underlying pathophysiology mechanism of diastolic heart failure. Can you explain us what happens in a patient with AL amyloidosis?
Yeah, sure. In general, what's happening is the light chains are depositing in the myocardium, and the what we call ventricular chamber capacitance, that is the size of the inner chamber of the heart, is getting smaller and smaller and smaller over time. That's the amount of blood, if you will, that the heart is able to hold. We also call that physiologically the end diastolic volume. So an average heart holds about 100 milliliters of blood. When it's done pumping, it holds 30, so it pushes out 70. And as you can see from this echo clip here, this particular patient has atrium shown at the bottom that are literally bigger in size than the ventricles, and that's not normal. And that's because there's been what we call progressive diastolic dysfunction and a reduction in the size of the ventricular chamber capacity. Physiologically, what we see happen, if you remember from basic physiology, is that the end diastolic pressure volume relationship, which is the curve at the bottom in this graph here, shifts upward and to the left. And so the heart has less and less blood inside of it, and accordingly the stroke volume declines. When your stroke volume goes down, so does your cardiac output. And declines in cardiac output are going to then result in declines in blood pressure. So back to what Margie was mentioning, many of these patients have high blood pressure. You're prescribing medicines. They no longer seem to need the medicines. You're peeling them off and their hypertension's going away. And so the declines in stroke volume, cardiac out, and blood pressure lead to this essential role for what I call in geriatric cardiology deprescribing, that is, removing medicines because they're not necessary. These patients need a pretty fast heart rate to maintain their cardiac output, so beta blockers are not well tolerated. And as Margie was saying, the classic neurohormonal antagonists, ACE inhibitors, angiotensin receptor blockers, and the novel ARNI therapies are often also not well tolerated. This is not to say that you shouldn't give them in anybody, but you should be careful and cautious.
Let me get to that point. I mean, I think for hematologists, it's really important, to understand that patients need a higher heart rate in order to have an appropriate cardiac output. What can we tolerate? At what point do we have to interfere? Is a heart rate of 100, 110 absolutely okay for a patient with a low end diastolic volume?
Yeah, I mean, it may be perfectly fine. And so you have to be a little bit more liberal. Remember, a normal heart rate is considered a range between 60 and 100. A heart rate of 60 is too low usually for an amyloid patient. And in some patients who are in AFib with a rapid ventricular response, they may need a heart rate of 100 and 110. And I don't think you should reflexively, especially in a patient who's got a relatively low blood pressure and advanced amyloid, start adding high dose beta blockers on the idea that I'm going to reduce the heart rate. That may be their compensatory response, and you're actually taking it away, and they decompensate in that setting.
And I have to be honest, I had my aha moments where I stopped the beta blocker very bravely, and patients felt so much better. This can be an important step really on the quality of life of the patient.
Yeah, I mean, parenthetically, I would say we have some data in TTR to show that stopping the beta blocker may be associated with improved survival. So it's not just making them feel better; they may live a little bit longer. It's pretty bad therapy for some patients.
Matt, any general comments? What you do with patients with cardiac amyloidosis, anticoagulation, etc.? Any recommendation?
Yeah, I mean, I just highlight 2 points I think, on this slide, or maybe three. One is certainly these patients are very high risk in the bottom middle for atrial fibrillation. They have, when they develop AFib, they have a high risk of intracardiac thrombi and a risk of embolism, irrespective of any scoring system. So there's something called the CHADS VAS score that we use in general cardiology to say you're of a certain age, you have hypertension, you have heart failure. We're going to decide who gets an anticoagulant based on your score. That's not the case in amyloid. You see AFib, you anticoagulate the patient because their thrombotic risks, as Margie was saying, were very, very high. Additionally, Margie always underestimates, kind of her import, but she spends hours and hours working with patients. She'll point out, educating them about heart failure and controlling their fluid balance, particularly patients with amyloid. They're very load labile and they really walk a narrow tightrope. And so, you got to be really judicious with the diuretics and salt intake and so forth. Probably bradyarrhythmias are much more important, to be honest, in amyloid, and probably much more common in TTR than AL. And while ventricular arrhythmias are not rare, they're rarely associated with a malignant event. And there's really no proven role for an ICD as a primary prevention. So those are some general treatment comments.
So what happened with your patient?
Well, this gentleman we saw many, many years ago. He was diagnosed by an endomyocardial biopsy. We always like the term, why did Willie Sutton rob banks? Because that's where the money is. And so an endomyocardial biopsy is a very simple and straightforward way to get to the diagnosis. And we can talk further about how he was treated down the road. But he was diagnosed with AL amyloid with an advanced phenotype.
Yeah, Matt and Margie, that was really a great case from, I would say, the perspective of a cardiologist. So maybe I can share a case with you, which I usually see other patients, how they are referred to me. And I just want to discuss a patient who is 65-year-old. It's Eileen, who has a history of diabetes, hypertension, and she has an MGUS for almost 3 years with elevated free light chains. So she is seen by a hematologist, and her MGUS is completely stable. Her PCP performed the routine checkup and saw that the patient had proteinuria combined with high cholesterol levels, also triglycerides. So in a 24-hour urine, the patient had over 6 grams of protein in the 24-hour urine, and she didn't have any other symptoms, no shortness of breath, dyspnea on exertion, no coughing, fever, no unintentional weight loss, but she had a slight +1 pitting edema. So the primary care physician sent her to nephrology for proteinuria, and the nephrologist exactly kind of, did the right thing. He thought immediately about, potentially AL amyloidosis, the combination of high proteinuria, nephrotic syndrome with high triglycerides and cholesterol in combination with elevated lambda light chains is kind of, very suspicious for AL amyloidosis. So the nephrologist did a kidney biopsy, and the kidney biopsy was congruent positive. Appropriately, that biopsy was sent to the Mayo Clinic for mass spectrometry, and the mass spectrometry confirmed lambda AL amyloidosis. So other workup performed by the nephrologist was a negative SPEP, but positive lambda light chains in the urine, and the patient also had a normal creatinine and GFR over 60 milliliters per minute. So subsequently, the hematologist was a little bit embarrassed to get the patient back from nephrology and completed the workup. And I think it's important that the hematologist really is the primary person or the primary caregiver who makes sure that there's a workup for all organs. And what the hematologist did was especially looking how high are the light chains. The kappa light chains were normal. Lambda light chains were elevated with 8. You know that in AL amyloidosis, we look more for the difference of the kappa lambda light chains. And the difference was around 7. The patient already had low IgG of 302. Patients can lose immunoglobulins when they have renal AL amyloidosis, and subsequently that can lead to hypergammaglobulinemia with increased risk of infections. Also, albumin was reduced. Patients with AL amyloidosis lose mainly albumin via their kidneys. The patient had a slightly elevated ESR, but otherwise the blood counts were unremarkable with a normal white blood count, a little bit decreased hemoglobin, but normal platelets. Troponin T was slightly elevated with 0.02, and NT-proBNP also slightly elevated with 721. So for the workup, the patient had a bone marrow biopsy, and the bone marrow biopsy revealed, which is very typical for our patients with AL amyloidosis, 3% lambda-restricted light chains by immunohistochemistry, and FISH showed a translocation 11-14, which we see in around 60% of the patients. It's more common in AL amyloidosis than in multiple myeloma. There was no amyloid detected in the bone marrow, and I have to say we rarely see really amyloid in the bone marrow, mainly in advanced cases. To complete the workup and really separate that case or AL amyloidosis from an overlap with multiple myeloma, the patient had a skeletal survey that was negative. You could also do a PET-CT or low-dose whole-body CT scan. The principle is to make sure that the patient doesn't have lytic lesion. It would not necessarily change the management, but it's important for the prognosis to know whether this is primarily multiple myeloma with amyloidosis or primary AL amyloidosis. A fat pad biopsy was not performed in that patient because once you have a diagnosis, it's not necessary to biopsy other organs. One organ determining AL amyloidosis is sufficient for those patients. So the patient is now concerned about the cardiac involvement and is not really sure whether the he or she sent the patient to cardiology. And I think that's a big question for most of us hematologists. Matt, maybe, and Margie, maybe you can comment on this. When do you think it's necessary that you get involved in the care of patients with amyloidosis? I mean, we all know that probably there is a minor amyloid in the heart of patients who are completely asymptomatic. Should we send all the patients, only the sickest ones? Is there a threshold? What do you think is an appropriate referral?
Yeah, I mean, I think that's a good question. In general, this is a complex disease, and so I think it's probably better to engage multidisciplinary team members, as early as possible. The hematologist here did a fantastic job at getting, all the necessary tests to, as you're pointing out, essentially expound that this patient has a pretty minimal cardiac involvement. Their troponin is slightly positive, but below the threshold. Their BNP is pretty low. It's unusual for someone this age to have normal diastolic function to begin with, never mind someone with amyloid. So my general sense is, this patient may be the rare patient who's a little too early to necessarily see a cardiologist. I guess the one time this comes up often is in the context of, treatment strategies and whether or not you're going to entertain a stem cell transplant, which would not be unreasonable to consider. And in that circumstance, if someone's going to undergo a stem cell transplant, as you well know, I think it's a good idea to get all members of the team to meet the patient. Even patients who have mild cardiac involvement who undergo a stem cell transplant could have lots of issues related to fluid alterations, volume retention. And as Margie mentioned, there's heaps of atrial arrhythmias that occur during the inpatient stay. And it's better to meet someone in the outpatient setting, get to know them, because I think they'll be more comfortable if you're pursuing that kind of line of strategy. But those are some broad comments. I never think it's wrong to engage a colleague in consultation.
I mean, in practical terms, if the patients are in good shape and have minor cardiac involvement, we send the patient to you to make sure that they are transplant eligible. And if they are really sick, we need you to manage the heart failure. So I think at the end, you see most of the patients. Yeah. I mean, what that patient, the patient also received a cardiac MRI, and cardiac MRI can be also useful for the diagnosis, prognosis, and monitoring of AL amyloidosis. And indeed, that patient, despite the patient having a low or almost normal troponin and NT-proBNP, the MRI was positive, and it showed an increased T1 extracellular volume and also late gadolinium enhancement. And there's some data that if you see that patients have really a high extracellular volume and late gadolinium enhancement, which is transmural, that those patients have really a poor prognosis. So interesting that even MRIs can help you and to determine the prognosis of those patients. But that brings me really to, I would say, the next problem. So once you have the diagnosis, the patient comes in, and most of the patients are devastated. They read online, my prognosis is so poor, I have to live half a year. And what I usually do is I try really, based on the data, to tell the patient, let's kind of do the complete workup to determine your prognosis. And let's see to what extent your heart is involved, because this is what we know. The heart really determines the prognosis of AL amyloidosis, followed by a hematological response, organ response, and then other factors, such as how many organs are involved, translocation 11-14. And I think doctors who treat AL amyloidosis, I mean, this is the only area where really tumor response does not really matter as much as an involved organ. So again, heart is really important. And that brings us to the staging systems. There are, I would say, roughly 2 staging systems that's mostly used. Both were published by Dr. Kumar from the Mayo Clinic. I usually prefer to use the revised staging system that was published in JCO in 2012. And why is this? It includes the free light chains. It includes troponin T as a marker for the heart, and also NT-proBNP. And you can get points. If the difference in the free light chains is more than 18, you can get a point. If troponin is above 0.025, you can get another point, or the NT-proBNP above 1800. So the system includes 2 markers of the heart and 1 hematologic marker reflecting, I would say, the tumor burden. And so if you are above all those 3 criteria, you get 3 points, which gives you a stage of 4. And I think what you can also realize is if you compare the outcome of patients with stage 4, which is 5.8 months, versus stage 1, which is over 90 months, this is really significant. This goes back to what we discussed initially, that early diagnosis at stage 1 can really save lives. Just a simple kind of recognizing this is AL amyloidosis. And I think kind of, this is really important, and we can only repeat this on and on and on. So once a patient has a secure diagnosis, you refer the patients to other disciplines for the better management, and you have the staging. I think it's important really to discuss kind of, what is the best treatment option for those patients with AL amyloidosis. And coming back to our patient, altogether, our patient is a 65-year-old woman with AL amyloidosis with stage 1 renal involvement and also stage 1 revised Mayo staging with a good prognosis of 94.1 months. So how do we treat that patient? What is kind of, really the best option? Is it Daratumumab? Is it transplant? Is it a combination of both? But before kind of, we start to go ahead and really treat the patient, Margie, the patient comes to you. What would you tell the patient? What should the patient do during chemotherapy? What are the important factors for the patient to pay attention to?
Sure. So, all the patients that I see have cardiac involvement, so maybe it might be slightly different. So, a lot of what I focus on with patients when we see them is to spend a lot of time educating them about, the disease process and how it has affected their heart. But most importantly, we like to empower them to actively participate in the management of their disease. So particularly heart failure management. I always tell every patient when we meet them to start, if they haven't already, start recording their weights every day, to keep a log at home with just the date and their morning weight, and to please call me if they have weight fluctuations of 2 pounds in a day or 5 pounds in a week, to let them know that's, usually fluid, that real weight doesn't come on that quickly. So that would be, a sign to reach out to your provider. Along the same lines, it doesn't take much to over-diurese these patients. Like Dr. Moore mentioned, it's sort of like walking a tightrope. So we want to say, in the same breath, if they're starting to feel dizzy, lightheaded, if they're feeling, on the dry side, to also feel free to reach out. depending on the relationship with the patient and their health literacy, sometimes, I like to give guidelines. If your weight is above this, you can take an extra dose of your diuretics. But for the most part, I prefer them to contact our office just because then at least we can know, changes in their clinical condition and things like that. And also, I think as Dr. Lynch will probably go into detail, they typically do receive steroids with chemotherapy, which can cause fluid retention. So we do some education about that, saying, the day of your treatment or a day or two after, you will likely need more diuretics. So, feel free to reach out to us so we can guide you with that. And then also importantly, we do provide a lot of education about sodium restriction. We usually say less than 2 grams a day is the goal. And I like to educate them that because of this cardiomyopathy that they have, they're in a salt-avid state. So it's really easy for them to be tipped over the edge by a salty meal. So I encourage them to track the sodium that they're ingesting, and depending on the patient and their personality type, we may refer them to nutrition for extra support. Some patients can't stand the fact of an extra Zoom call, which I understand, but some people do really like the extra support. So sometimes we do place that referral. And then I also just give basic instructions for other reasons for which to call, which can signify fluid retention beyond just the number on the scale. So that would be primarily like orthopnea. I tell them if you're starting to sleep on 2-3 pillows at night, or you're moving to the recliner, this is not normal and you should be calling me. If you notice swelling in your legs, bloating in the stomach, if you're waking up at night short of breath, all these are reasons to reach out to us. And then lastly, I do just always encourage them to engage in some form of physical activity if they're able to. A lot of times I know patients are a little nervous to exercise once they get this diagnosis. They feel overwhelmed. They may be, having some anxiety or depression. And I just try to encourage them to try to find a way to incorporate movement into their lives. Walking, of course, is great. A lot of times we recommend getting a recumbent bicycle or using that at the gym, just because a lot of these patients are also fall risk, just, between the neuropathy and the orthostasis. So it's just a safe option for them. It seems kind of like a no-brainer, but it's important for all of them to find ways to, exercise and move and keep their bodies strong as they undergo chemotherapy and potentially stem cell transplant. It's good for them to be as robust as possible. And then also nurse practitioners or any provider can help the patients with side effect management, with basics like antidiarrheal agents or antiemetics, just to make treatment more tolerable.
Perfect, Margie, that was really great. What I really like to give the patient is a list with the task to record the weights. This helps the patient tremendously because patients realize that when they have a salty meal, the weight goes up, or when they receive dexamethasone chemotherapy, the weight goes up. And they really learn to read their body. And maybe if the patient is educated, can manage diuretics to a certain part. Margie mentioned that it's better to really call, that we know what's going on. But some patients say, my weight goes up 2 pounds or 4 pounds with the chemotherapy. On that day, I prophylactically double my diuretics. I mean, those things are really important to make sure that the patient understands, a salty meal is not good and what happened with the chemotherapy. Margie, that was excellent. Thank you so much. But let's also discuss what are the goals of therapy. I think in AL amyloidosis, it's very important that we induce a deep remission, complete remission, or MRD negativity. In certain cases, achieving a VGPR, a very good partial remission, might be sufficient, but only in combination with an organ response. So if you see that the patient has improvement of the proteinuria and achieved a VGPR, you might accept that. But if you see that the patient has a lack of organ response or worsening heart failure, worsening proteinuria, a VGPR might not be the right endpoint, and the patient might have a low level of lambda light chains still building up amyloid. So that's why CR, I think, should be the goal of the treatment, and maybe MRD negativity. We talk a lot about MRD in multiple myeloma, but it might be even important for AL amyloidosis, where the smallest amount of light chains can contribute to the buildup of amyloid. So how can we achieve those deep remissions, I think Daratumumab, that's a treatment that was approved by the FDA earlier this year, is a standard of care for patients for newly diagnosed AL amyloidosis. Daratumumab is a monoclonal antibody. You're well aware of this. Is relatively well tolerated in AL amyloidosis, and the combination with CyBorD, cyclophosphamide, Velcade, and dexamethasone is very effective. I want to point out that it's really important when you have the different stages of AL amyloidosis that you dose decrease the steroids, the dexamethasone, according to the stage of the disease. In very advanced stages, I give dexamethasone in dosages of 8 milligrams. And if patients tolerate that well, you might increase the dose, but make sure that you don't start with a brutal regimen. Patients can decompensate easily, even with 10 or 20 milligrams of dexamethasone. So having said this, it's pretty clear that the newly diagnosed patients should receive a combination with a monoclonal antibody, Daratumumab. So what do we do for our relapsed patients? It's not that easy because a lot of medications are not well tolerated for patients with AL amyloidosis. Revlimid, pomalidomide, the immunomodulatory drugs that are I would say, really the main treatment for multiple myeloma are not tolerated in patients with AL amyloidosis. Patients can have worsening of their heart failure. Many patients have neuropathy, so you might really be careful with bortezomib. And carfilzomib, a very potent proteasome inhibitor, is not recommended in patients with AL amyloidosis due to cardiotoxic side effects. So we don't have that many options left, but again, the Daratumumab is a very powerful treatment. And at ESGO this year, the Andromeda data were presented, and they showed very impressive data when you compared Daratumumab with just CyBorD. It almost doubled the response rate from around 30 to 60%. Very impressive data. And those data only reflect the complete remission. And I mentioned already that only a deep remission, a complete remission, really transfers into organ response. And that was also what we saw in that study, that the organ response almost doubled when you compare Daratumumab versus CyBorD. So you can see that here, that the cardiac response rate as well as a renal response rate in the updated analysis at ESGO 2020 almost doubled. And again, going back to a deep remission, I think this is only possible if you induce a high rate of complete remissions, then this will also yield in a high rate of organ responses. There are many questions on Dara safety and AL amyloidosis, but I can only say that Daratumumab is very well tolerated, especially the subcutaneous version of Daratumumab. It decreases the volume for the patient. A problem is if you give the co-medication, especially steroids, to avoid CRS, cytokine release syndrome, that usually leads, especially in the beginning, to some volume overload in those patients. But otherwise, I think Daratumumab is really kind of, one of the strongest medications we have in AL amyloidosis. And there are also data for the relapse setting with Ixazomib, for instance, which are very powerful and also well tolerated. We discussed already the transplant, autologous stem cell transplant in patients with AL amyloidosis. So I would say around 15 to 20% of the patients have an early stage AL amyloidosis and are candidates for an autologous stem cell transplant. But the question is, I just showed you the data from Daratumumab. If so many patients have a complete remission and achieve maybe MRD negativity, what is the role of transplant? And everybody handles that a little bit different. We in our practice, usually when patients achieve a complete remission, and even if they're MRD negative with Daratumumab, we don't push the transplant. We usually reserve the transplant for patients who have I would say, an early stage AL amyloidosis, good performance status, and do not achieve a complete remission, have persistent plasma cells, and have no organ response. So those are the data. But maybe, Matt, what do you think from a perspective of a cardiologist? What would be the ideal patient for autologous stem cell transplant? What are your criteria to determine whether the patient is transplant eligible or not? Because I think that is really important that you don't transplant patients who have advanced disease, cardiac disease, and then end up when they have a sepsis, for instance, in the ICU, or even worse, die from transplant.
Yeah, I mean, I think obviously transplant is a very cytotoxic therapy for the plasma cells, and can achieve a prolonged CR. But as you're pointing out, in people certainly with advanced cardiac involvement, the mortality treatment-related could be quite high, upwards of, God forbid, 10, 20%. You've highlighted several of the features, right? I mean, it should be reserved for people typically under the age of, I'd say, 65 or 70. They should have a reasonable New York Heart class, avoid people who have class 3B or 3B symptoms, certainly those with class 4, markedly elevated cardiac biomarkers. As we explained, when the heart can't pump a lot, the stroke volume goes down and so does the blood pressure. So if the patients have a very low blood pressure, that's a bad sign, especially if you need to give them, for example, midodrine to support their blood pressure. Other concomitant organ dysfunction also can complicate things. So heart failure is bad enough. If they have heart failure and nephrotic syndrome, that would make things a little bit more difficult. The daily dose of diuretics that they take is often very helpful to gauge how severe their disease is. People are taking more than, if you will, 1 milligram per kilogram of Lasix. So if they're taking 80 or more and they weigh 80 kilos, that's quite a bit of diuretic. You'd be careful and cautious. And as you know, at times we struggle with this decision making. We kind of take a tact of shared decision making with the patient, but we've often leveraged a cardiopulmonary exercise testing to try to evaluate someone's real functional capacity to see if they have enough reserve to really tolerate this. There are rare cases also where nothing's working and you're forced, despite them being high risk. With your expertise and that of our transplant colleagues, we've gotten people through what are otherwise candidates who you wouldn't really want to pursue transplant, but they really had no other options. So.
Yeah, excellent. Yeah, and it reflects, when we transplant, we really rely on our cardiology team. We really ask, can we do this? This is not a decision a hematologist can make in AL amyloidosis. So very important. Thank you, Matt. But let's go back. Patient had a transplant and is relapsing. That's a big question. We don't have that many options in AL amyloidosis. I mentioned already. You have to be careful with carfilzomib, with all the IMiDs. So what are the choices? And there were a few studies, that might help us in the future. One study was a phase 3 Tourmaline AL study, and I want to mention that here, despite the study was negative, it compared Ixazomib with dexamethasone versus physician choice. Maybe not the best strategic design, but the study showed that the complete remission rate is kind of increased from 18 to 26% in patients who received Ixazomib, but altogether the study was negative. It failed its primary endpoint of the overall response rate. So that was a little bit disappointing, despite, the complete remission rate was higher. What we also saw was that the median duration of hematologic response was better in the group that was treated with Ixazomib. It increased from around 20 to 46%. So that was quite encouraging. And also when we look for the time to vital organ deterioration, it was much longer in the Ixazomib-Dexamethasone group with 34.8 months compared to physician choice with 26.1 months. So the data altogether encouraging. I think it is a good option. It's in most of the patients very well tolerated, but unfortunately it was altogether a negative trial. Another drug that is very important, and a lot of people talk about that, is venetoclax. That's a BCL2 inhibitor, which we took from patients with CLL. It's given as a pill, and it has really remarkable efficacy in patients with AL amyloidosis carrying the translocation 1114. We don't have any prospective data, but we have a large retrospective analysis that was performed by one of our fellows here from Columbia University, and he collected data from around the world on patients with AL amyloidosis treated with venetoclax alone or in different combinations, mainly with a proteasome inhibitor. And what we found was that the response rate is really remarkable, 63% VGPR-CR in all patients. But if we separate the patients into positive for translocation 1114 or negative, you can see that the VGPR-CR rate goes up to 78% when patients carry the translocation 1114. This is really very encouraging, especially due to the fact that the BCL2 inhibitor venetoclax is a pill. It's given as a pill, and it's relatively well tolerated, so you don't struggle with volume overload or the patients have to come for infusions. So several trials are opening soon, hopefully, and I'm pretty sure that venetoclax or maybe a BCL2 inhibitor will be part of the treatment in the future. So having discussed also the treatment for relapsed AL amyloidosis, maybe we can finish here and but discuss a little bit the take-home messages. I don't know, Matt and Margie, what do you think are the 3 take-home messages for patients with AL amyloidosis for the management team? What should the management team really kind of, pay attention to?
I'll start. Margie can chime in. I think in general, I would say that it's incredibly important, as we mentioned several times, to entertain this diagnosis in your differential. If you don't think of a diagnosis, you'll never make it. And so I think the problem here is that amyloid is often left off the differential. People conclude it's hypertensive heart disease or heart failure with a preserved ejection fraction, and not get to the true etiology. We didn't spend a lot of time today. We focused on obviously AL amyloid, but it's incredibly important to, type the amyloid and make sure you have the correct type in order to choose the effective treatment. And then as Margie demonstrated, I think it takes a village to take care of one patient with this disease. I think everyone can appreciate having the expertise of a hematologist like Dr. Lynch, nephrology colleagues, hepatologists, pathologists. But I'm eternally grateful to Margie. She and the rest of the nurse practitioner team do an amazing job of really providing day-to-day care to patients in a manner that is beyond exemplary and is necessary, I think, for us to achieve the outcomes that we're starting to see. Margie, things to add?
Yeah, thank you so much. I agree. I think it's so important. I think we're really lucky to have a team of cardiologists, hematologists, oncologists, and advanced practice providers who all just regularly communicate with each other. I think our patients really benefit from that strong collaboration.
Absolutely. That gives me the opportunity to say that we have the Columbia Amyloidosis Multidisciplinary Program. We meet regularly, we discuss our patients, and I'm very grateful that really I have experts like Matt and also Margie in that team, because it's so much easier to pick up the phone and discuss a patient. My take-home message, in addition, would be make sure if you have patients with lambda MGUS that you pay attention to the possibility that that patient might have early AL amyloidosis. Consider to do an NT-proBNP or 24-hour urine. That really helps to make the diagnosis much earlier. And remember, the prognosis is so much better when you diagnose patients much earlier. That concludes our panel discussion on AL amyloidosis, showcasing how it takes a team to effectively manage patients who present with this complex disease. I hope you found this program interesting and useful for your practice, and thank you so much for joining us.
Thanks for having me.
Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KKH860. This activity is supported by an educational grant from Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, PeerView Institute for Medical Education.